Hi, everyone. I'm very excited to be giving a presentation again this year. My name is Amjad Kanj. I am a second-year fellow in the Department of Pulmonary and Critical Care Medicine here at the Mayo Clinic. And the topic for today's presentation will be about common respiratory diseases in older adults. And we will be focusing on some few novelties or changes in practice that happened over the past few years that may also be of interest to you. So before we begin, a quick review of some of the basics of the respiratory system. So inspiration or inhalation starts when the diaphragm contracts and the lung expands. And this creates a negative pressure within the lungs and drives air in through the conducting airways into the respiratory airways and capillaries. And this is where gas exchange occurs. Now, inspiration or inhalation, as you may recall, is an active process. So we initiate that by contracting our breathing muscles, whereas exhalation is mostly a passive process. And any insult or injury that happens over the years that affects any of these structures, from the diaphragm down to the capillaries, can lead to respiratory disease. For example, patients with ALS or advanced ALS are unable to use their breathing muscles, so the diaphragm doesn't contract. And that's why these patients, often will have tracheostomies or openings in their neck through which air goes in. These patients will also have a weakened immune system from their disease and may also have weakened upper airway muscles. And this puts them at risk for aspiration, especially when they eat. And that's why they get often admitted to the hospital with pulmonary infections or pneumonia. Now, here is an alveolus, and this is a blood capillary. And this is oxygen going from the alveolus into the blood capillary. And this is gas exchange. And another example of diseases that can occur at this stage of breathing is patients who have smoked for so many years, for instance, and these will develop problems in their alveoli here, which can impair gas exchange. And this is what we refer to as COPD, which can manifest as some sort of alveolar destruction. Now, age by itself is also a risk factor for blood clots in the pulmonary artery, which is the large vessel that leads to the lung or to these capillaries here. And blood clots, when they form in the pulmonary artery, can impair gas exchange and oxygen diffusion. And we'll talk about this in more details later on. So the important question, and this is the main question for today's presentation, is that what happens to our respiratory system as we age? And it's an important topic, and there is still some debate around this. But one thing that we all tend to agree on is that there is a natural decline in lung function, and this starts as early as age 25 or 30, somewhere around 25 to 30. And you can see here on the graph that with every year, there is tiny decline in lung function. And additionally, with age, besides this natural decline in lung function, we will also have increased mucociliary dysfunction. And cilia are these hair-like structures here that are present in our airway and that help get rid of microorganisms and particulates like dust, for instance. And we will also have decreased muscle performance. And this is simply by this natural aging process of muscles. And then finally, we will have decreased cough strength. And then when we, add all of these together, these will contribute to airway clearance, to poor airway clearance, which, when you add to a weakened immune system that happens with age, puts the older adults or the elderly at risk for lung infections. And lung infections or pneumonias, which can be viral, bacterial, or fungal. And this is how pneumonia looks like on a chest X-ray here down in the corner. So this black area here in the lung or blackish area, this is how a normal aerated lung looks like. And then this white opacity here or abnormality in the left lung is a pneumonia. And common symptoms of pneumonia include fever, cough, shortness of breath, and chest pains. But sometimes, and especially in older adults or the elderly population, pneumonia can manifest in many different ways. And sometimes this could be a loss of appetite, weakness, confusion, low energy, and these could be signs of pneumonia. Now, who are at increased risk for pneumonias? Immunocompromised, including the elderly, patients who have chronic diseases like asthma, COPD, or who are chronic smokers, and then patients who have or are at risk of aspiration. Now, another lung disease that becomes much more common as we age is lung cancer. And the median age for lung cancer diagnosis is 70 years. And as you can see here on this graph, over 50% are diagnosed after the age of 65. And smoking remains the most common risk factor for lung cancer. Other risk factors include genetics and radon gas as well. I like this slide a lot, and we'll go over it together here. And this really highlights how far we have come in the treatment of lung cancer over the years. And you can look here in 1940, where we only had one chemotherapeutic agent at that time, whereas now we have several chemotherapeutic agents that we can use in addition to targeted drugs or targeted therapy and then immunotherapy. And I'll explain the difference between targeted therapy and immunotherapy because I believe these are important to know, not only for lung cancer but also for many other cancers. Targeted therapy or targeted drugs are drugs that target some differences that are found in cancer cells that are not found in our cells. So there are some areas that are specific for the cancerous cells, and we test the cancer cells for these areas or these parts. And if we find them there, then we can use some drugs that target these areas in the cell. And this is called targeted therapy. So we give this drug that goes and attacks the cancerous cell if there are these certain areas or certain receptors or proteins that are on these cancerous cells if they're present. Whereas immunotherapy is completely different. Immunotherapy, these are drugs that will stimulate or boost our immune system, and then our immune system in turn will be attacking the cancerous cells. So immunotherapy really doesn't depend on on how the cancerous cells look like or what kind of receptors they have. It depends more on our immune system and the function of our immune system. And we also use radiation therapy commonly for some types of lung cancer or some stages of lung cancer as well. And over the past few years, over the past decade, and even less than that, we have come a very long way, as I mentioned before. And the old days, and maybe, even 10, 20 years back, we used to say that patients who present with stage 4 lung cancer, have barely a few months to live, or a year or 2 years. And now we're seeing patients, with immunotherapy and targeted therapy, we're seeing patients that are living more than that, and sometimes much more than that. Now, another disease that also tends to occur much more in older adults is pulmonary embolism. And we talked about this briefly before. These are usually blood clots that form in the veins of the legs, and then they travel up to the right side of the heart. And then from the right side of the heart, they go to the lungs. And major risk factors for these DVTs or PE include restricted mobility, recent surgeries, cancer, obesity, and advanced age. And restricted mobility is common in elderly adults, and that's why walking and staying active is crucial. But also surgeries are more common in elderly patients, cancer are more common, obesity are more common, and that's why these clots are much more common in elderly. And this is how a leg with DVT can look like. Not always, this is probably I would say this is an extreme example, but it's also common. I would say that one of the biggest clues that will make you think of a DVT if there is some sort of an abrupt or sudden asymmetry in the lower extremities. So one leg looks different than the other, one leg is more swollen than the other, one leg is more warm than the other, etc. So these are all things that would prompt a physician to do an ultrasound of the veins to look for clots. And it's important to recognize these clots. It's important to diagnose them early on, especially that they can travel up to the lungs, as we mentioned before. And this is how a pulmonary embolus looks like. So we do a CAT scan with IV contrast, or we use a dye, special dye that goes into our vessels. And once this dye gets concentrated in our pulmonary artery, we take these images, and then when there's an area of where the dye is really not reaching it, like here, this is a defect. This is an embolus. So this is how we identify these clots on CAT scan. This is your pulmonary artery, and then this is a blood clot here. Now, we have also come a very long way in the treatment of these blood clots, and in the older days, and we still use, we used to use Coumadin much more often than much more than we do now. And Coumadin or warfarin, that's the other name for it, is a blood thinner, or what we call anticoagulant, and what's commonly used to treat these pulmonary embolisms. But the problem with Coumadin is that we have to monitor labs very frequently. And we have Coumadin clinics where patients who take Coumadin or warfarin go to probably every week or so to get some blood tests, just to make sure that they're taking the right dose and things like that. So may not be very practical, I would say, for so many patients. And then the concentration of Coumadin or the amount of Coumadin that reaches the blood also depends on so many things, including the diet and things like that. So recently, we have a different class of medications different than Coumadin, and we call these DOACs, DOACs, or direct oral anticoagulants. And these include drugs like apixaban or Eliquis, rivaroxaban or Xarelto, and then edoxaban, dabigatran. And these drugs have several advantages over Coumadin. One is that we don't have to monitor the level the way we do with Coumadin, and then two, they're less affected by diet to some extent, and by other medications also that we could be taking. So the level doesn't really depend on different medications and things like that. And what's new here is that we are expanding the use of these drugs to different populations. In the past, there was we used to have select criteria, and we used to have a smaller group of patients to whom we could prescribe these drugs. But recently, we started using them in patients who have cancer, and these patients used to take other anticoagulants before. Now we're prescribing these. We're also using them in elderly patients. We're using them in patients who are a bit overweight, and patients who have kidney diseases and things like that. So we're expanding the use of these drugs. And I would say now that probably most or the vast majority of patients who have pulmonary embolisms and also atrial fibrillation or other things that would require anticoagulation, most of them end up being on one of these drugs here. Now, a completely different disease that also affects the elderly population is obstructive sleep apnea. 1 in 5 older adults will have obstructive sleep apnea, at least I would say. We think that OSA or obstructive sleep apnea is underdiagnosed. And OSA is more common in men than women, as you can see here. And this has to do with some anatomical differences mostly, especially in the neck area. And two main reasons why the prevalence of obstructive sleep apnea increases with age. One is that, as we age, we get increased fatty deposits in the parapharyngeal area, or in the area of the neck here. And this happens especially in men. And this predisposes them to having obstructions or upper airway obstruction, especially when they're sleeping. And this is the time when muscles are most relaxed, and this is where we get we tend to get obstruction. And then postmenopausal women, with changes, with hormonal changes that happen, also tend to gain some weight and tend to have some changes that would predispose them to having obstructive sleep apnea. Now, why it's important to treat obstructive sleep apnea? And this is because untreated obstructive sleep apnea could lead to a number of diseases. And these could range anywhere from mental health problems such as anxiety, brain fogginess, depression, to other much more serious or life-threatening conditions, I would say, such as congestive heart failure, arrhythmias, and strokes. And we have some, screening tools for obstructive sleep apnea, and primary care physicians often use the Stop Bank questionnaire, which we'll discuss in a bit, or may offer to do an overnight oximetry, which is a test that continuously monitor oxygen level overnight, and then may give us some clues into whether a certain patient could be having sleep apneas or apneas during sleep. And the way to diagnose sleep apnea is by sleep study, and this is what we refer to as polysomnography. And these days we're doing this more commonly at home, but in the old days we used to do it in the lab. Now, there are some patients that still required to come to the lab to do the sleep test, and this includes patients who have, for instance, severe congestive heart failure, because these patients are at risk for other forms of apneas called central sleep apneas. and heart failure, is a major risk factor for central sleep apneas. So we prefer to do sleep studies for patients with heart failure in the lab, just to differentiate between, these two forms of sleep apnea, obstructive and central sleep apnea, because they may have one of them, they may have both as well. Otherwise, most of the other patients with less serious conditions, such as diabetes, hypertension, or patients with no medical problems, these days we are doing the sleep tests at home. It's easier for the patients, and they would be sleeping in their beds, and probably easier for everyone. This is the stop bank screening tool here. So these are some things that would increase someone's suspicion for obstructive sleep apnea. These include things from snoring, fatigue, someone observing you having apneas, and this is important. We ask the patients, did anyone tell you, or anyone told you before, that you stop breathing when you sleep? And if the answer is yes, then our probability for sleep apnea or undiagnosed sleep apnea goes up. Blood pressure, hypertension, patients who are obese, elderly patients above the age of 50, patients with a large neck circumference, and male patients. And treatment for sleep apnea, the probably first-line treatment these days, especially for more severe forms of sleep apnea, is the CPAP here, that keeps the airway open during sleep. Alternatives, include oral appliances that will advance the mandible here to keep the airway open in the back. And then surgery is also an option. It's usually a last resort because of the side effects it carries. Now, some novelty here in the field of obstructive sleep apnea treatment, and this is a hypoglossal nerve stimulation, also known as Inspire device. And what it does is, this device has two leads. There is one lead that senses respiration. So the device knows when you're initiating a breath. So as you remember, we talked about inspiration being an active process. So the second you start taking a breath, this device, will know that you're trying to breathe, and then it will send the signal up to the nerve, to the hypoglossal nerve. And the hypoglossal nerve is the nerve that goes directly to the tongue. So this device will send a signal to the tongue so that the tongue advances when you're trying to breathe. And when the tongue advances, the airway tends to open. And this is how this device, the Inspire device, ensures that the airway is open whenever the patient is breathing in their sleep. Now, obviously, this device should be turned off when you're awake, or otherwise, every time you breathe, your tongue would be advancing forward, and we only turn it on when we go to sleep. And still till this day, it's being more commonly employed or used, but we still have a select criteria, and not everyone will qualify. And only a small proportion of patients, tend to qualify for this. And this depends on so many things, including the anatomy of the upper airway. So in summary, the things that we talked about, advanced age is a risk factor for pneumonias, lung cancers, pulmonary embolism, obstructive sleep apnea, and then other things that we briefly mentioned, such as aspiration and ALS. Now, the important question is, what are the things that we can do to counter the effect of age on our respiratory? First and foremost, staying active. Exercise has extensive benefits when it comes to our, circulation, when it comes to muscle size and strength, better ventilation, when it comes to our pulmonary function and capacity, when it comes to weight, and even when it comes to, blood clot formation. So staying active is very important. When you work out, your lungs exercise with you, and this is very true. Second thing is refraining from smoking. And this famous study that's, been there in the literature for probably over 30 years now shows that it's never too late to quit. So this in green here is the decline and the natural, decline in lung function that we talked about before, that usually starts at age 25, of someone who has never smoked. And this is the decline in lung function in red here of someone who smoked regularly. And if this person here decides to stop smoking at age 45, what will happen is his lung or their lung function will not go back to what someone who never smoked has, but the decline in lung function at the time they stopped smoking will mirror that of someone who never smoked. So even if you stop at age 65 here, you will see that your decline in lung function will parallel that of someone who never smoked. So that's why it's never too late. There is always a benefit in quitting smoking, even if you're in your 70s, 80s, and even 90s. Vaccination is important, and you've probably seen that with COVID lately. So two common vaccines that we tend to give our patients: the pneumococcal vaccine. Usually there are 2 doses, sometimes 3 doses if you've taken one before the age 65. So some smokers, patients with certain diseases like asthma and certain other diseases, related to the spleen and things like that, could have taken a vaccine before the age of 65. These patients will need 3 doses, including the one they took before 65. Whereas patients who have not taken any doses before the age 65, they will need to take 2 doses in their lifetime. Now, influenza vaccine is yearly vaccine. COVID vaccine, probably we may need to take another vaccine in the coming year. It seems like we may need to take at least, another dose or 2 in the coming year or 2. But we'll see if, we'll have to take this on a yearly basis. Respiratory etiquette, and, we've also been practicing this recently with COVID, avoiding close contact with others when they're sick, covering mouth or nose when coughing or sneezing, wearing masks these days, washing hands regularly, and this is very important. Washing hands regularly. And then finally, listen to your body. If you have any signs, any symptoms of any lung disease or any other disease, seek medical care. Always talk to your, primary care physician about symptoms or, things that you could be experiencing Do not ignore anything. I advise everyone to just openly discuss things, no matter how irrelevant they may seem to you, or not important. But not important things could turn out, may turn out to be important things eventually. So listen to your body. Now, just some interactive questions here, just to go over a few important things that we talked about. Valerie is a 72-year-old woman who lives by herself. She sees her physician for sleepiness and lack of energy during the day. She says that she sleeps at 10 p.m. and wakes up at 7 in the morning. She reports morning headaches and occasionally wakes up during the night with a choking sensation. Her physical exam is normal. She weighs 160 pounds. She most likely has A, lung cancer, B, sleep apnea, C, narcolepsy, D, anxiety disorder. So the answer here is B, sleep apnea. And some of the clues that point to this diagnosis are sleepiness and lack of energy during the day. Despite the fact that she's getting somewhere around 9 hours of sleep, still she's feeling tired during the day. And then when she wakes up in the morning, she reports morning headaches. And this is also one of, potential signs or symptoms of obstructive sleep apnea. And she also wakes up during the night with a choking sensation, and this is also another common symptom of, obstructive sleep apnea that patients may experience. And all of this is, despite the fact that she only weighs 160 pounds. So this tells you that, a patient doesn't have to be obese to have obstructive sleep apnea. Even patients, with a normal weight, and even those who are underweight could still have obstructive sleep apnea. So her physician orders an overnight oximetry that suggests moderate to severe obstructive sleep apnea. Remember that the overnight oximetry is a screening test. So now she has to do a confirmatory test, which is a sleep study. So she gets referred to a sleep medicine specialist, and the specialist recommends a polysomnography or a sleep study. So which condition would prevent her from having the sleep study done at home? Is it diabetes, hypertension, severe heart failure, or hypothyroidism? And the answer here is severe heart failure. And the reason why heart failure patients, especially ones with severe heart failure, should have their sleep study done at the hospital is that because heart failure is a main risk factor for another type of sleep apnea called central sleep apnea. And we're really not able to make, to differentiate or to make this distinction on a sleep study done at home. And we need more advanced tools to do that. And that's why we ask patients to come to the lab. Now, if her condition, or obstructive sleep apnea in this case, remains untreated, Valerie is at risk for stroke, A, B, heart failure, C, pulmonary hypertension, D, depression, and E, all of the above. And the answer here, of course, is all of the above, in addition to, a big list of so many other things that could also result from untreated obstructive sleep apnea. Different case here, Josh, 81 years, presents to the ED with chest discomfort and shortness of breath. He also has a dry cough. 4 days ago, he fell at the nursing home where he lives and injured his right knee. He has been resting in bed since then. On exam, his temperature is 100 Fahrenheit. His left calf is warmer and larger than his right calf. So Josh will most likely be prescribed A, antibiotic, B, anticoagulant, C, chemotherapy, D, anxiolytic. So what does Josh have? Let's begin with that. So he fell 4 days ago, so he's been immobile in bed for 4 days. He has a temperature, he has a fever, low-grade fever, and then his left leg is asymmetric when compared to his right leg. So there's an asymmetry between the left and the right leg. And this is a very important clue here that tells us that maybe this patient or maybe Josh, developed a blood clot or a deep venous thrombosis, DVT in his left leg. And these patients could also develop a pulmonary embolus, and pulmonary embolism and deep venous thrombosis are part of the same spectrum and are usually treated similarly. And the answer here is B, anticoagulant. And we could consider one of the new direct oral anticoagulants in this patient. Next, in a cold Minnesota winter, Tim, 65 years, smoker, presents to the ED with fever, chills, myalgia, sore throat, and runny nose. He also has a cough and is short of breath. His temperature is 103 degrees Fahrenheit. You order a chest X-ray. Meanwhile, and without any hesitation, you decide to prescribe the following: aspirin, and aspirin is a blood thinner, and an NSAID as well, non-steroidal agent, anticoagulant, Tamiflu, which is a commonly prescribed treatment for the flu, and then Lasix, which is a diuretic, commonly referred to as the water pill. And the answer here is C, Tamiflu. When we have a high suspicion for flu, especially during the winter or the flu season, especially in someone who is old, without hesitation, we prescribe Tamiflu until we, run the tests and get the test results back. If there is no flu, then we could stop the medication. If there is flu or we still have a high suspicion for flu despite negative tests, then we continue the medication. Now, the chest X-ray shows a pneumonia. His influenza PCR, which is the test that we do to check for flu, returns positive. He spent 3 horrible nights at the hospital. At discharge, he would like to know how he could have prevented this from happening. He explained to him that as we age, our lungs become susceptible to infection, and advised him to stop smoking, take the pneumonia and influenza vaccine, continue smoking as it's too late now to get any benefit from smoking, but take the pneumococcal and influenza vaccine. C, stop smoking, but no need to take any vaccines as they never work. And then D, take vitamin C supplements. And obviously here the answer is A. And the take-home message from this is that smoking cessation always has a benefit, irrespective of at what age you stop smoking. So it's never too late to stop smoking. And then definitely the vaccines will help. He's 65, so he is due for his pneumococcal vaccine, and then his yearly influenza vaccine, and maybe COVID vaccine as well. Okay, so take-home messages. Advanced age is a risk factor for lung infection, cancer, pulmonary embolisms, and obstructive sleep apnea. Yearly influenza vaccine and pneumococcal vaccine series have great evidence. When you exercise, your lungs exercise with you, so stay active. And I can't stress enough on this point. Daytime sleepiness, fatigue, morning headaches, depression, all of these could be symptoms of sleep apnea. and it's never too late to quit smoking. And thank you very much. And it was a pleasure to give this presentation, and hopefully we'll see you in person again next year. Thank you.